Hello, students. It is time for the answers to OQE Chapter 2. So, to begin, how receptive are parents when counselors inform them their child has been abused by a close family member? Are they open to counseling? This depends on a lot of things. Obviously, it's unique to each individual and family. I've worked with a young female who, stated that her brother-in-law, who was living with the family, had been abusive to her. The family initially was, kind of blown away by it. They then told me that the brother-in-law was actually, kind of older than the sister, and had been a family friend. Apparently, the family found out that he was in a relationship with her because she ended up pregnant. He said, I love her, I want to marry her. So, the father was like, okay, I'm not going to press charges. Like, this will, we'll do this, and so learning that he was then making sexual advances and being inappropriate with the younger daughter just really hit a lot of unresolved issues with the family, specifically with the dad. Once they found out that I was going to make a report of this, they basically told the brother-in-law to leave so that he wouldn't have to deal with charges. And it was just really difficult for the family to process through. They ended up telling my client to tell me that she made it up, and that she hadn't taken her medicine that day and that's why it happened. And so it just sort of depends. Other families are more open to hear it and want to do, okay, so what do we need to do? How do I need to help my child and create safety? In most cases, the abuse is going to be known somehow, and the client's going to come in with it, but there's definitely a lot of cases where it's going to come out in counseling. And so depending on the age of the child and depending on the situation and the circumstances and all of these different things, it just sort of depends. There are definitely people who might withdraw from treatment. There are people who may, say, oh, that's not true, that's not, really happening, and not want to work on it. It's going to be different across the board. Are adolescents less likely to admit that they've been abused by another adolescent because of pressures from their peers or environment to have sex? And so, again, this is very unique and different for each individual. There are some adolescents who disclose the information but don't even realize it's abusive. They're just kind of telling you stuff that's happening, and you kind of stop and say, wait a second, what's going on here? But there are far too often individuals of all ages that withhold this information. And so I actually, in the written document, have a link for a TED Talk about why women stay silent after sexual assault. So it's semi-related to this question. So if you want to watch that, but just make sure that, there is a trigger warning that sexual assault is being discussed and could be a difficult topic for you to listen to or to hear, depending on your circumstances. So one of the biggest issues in our world is that victims are often not believed. They get harassed, sometimes threatened because of their disclosures. And so that can create a big issue, again, amongst anyone, but specifically amongst adolescents. Coercion can also be a big issue where, again, the individual may not totally realize that it's abusive or assault because they feel like, well, in the end, I kind of agreed to it or went along with it, and they don't realize how coercion can play a part. Next, while reading the biopsychosocial, made me wonder how accurate or valid the information would be. And, this is really a good point, I think, that clients are not always going to be honest when we start working with them. They may not be honest at all at any point during counseling. They may not do so in the beginning, but then come out with it later. I had a client who I did her intake, and she denied any kind of abuse or trauma or anything like that. And she ended up working in a therapy group with other women, and eventually ended up talking about this enormous amount of abuse and trauma in her history, starting from a young age with her brother, and then with her first husband and other dating partners, and then her current husband and the way that he was being abusive to her, and just all of this stuff came out, and we ended up being able to really help her as much as we could, and help her to get moving forward and away from her current husband who was being abusive, but it's we're just never sure. We have to work with where the client is at and try to get to as much things as we can. Sometimes you get information from outside agencies and sources that you can kind of either confront the client on or at least kind of work with. But it really depends. Let's see. In agency work, sometimes you're going to have a really extensive biopsychosocial just because managed care, Medicaid, things like that, or county funding are going to require more things to be addressed. And so sometimes you're going to get a little bit more that way, or clients who are like, I don't want to answer these questions. Let me see. What else did I put? Since sexuality is one of the crucial areas of wellness, I believe it is important to at least ask some basic questions at the intake and then follow up more as treatment goes on. So if, a session they start talking about relationships or different activities or things like that, you can start kind of asking those questions as follow-ups. I've also completed sexual offender assessments where I've had to ask very extensive questions about sexual acts, behaviors, fantasies, and so on at the intake. And I would just hope for as much honesty as possible. And then with the sexual offenders, we would have a polygraph every 3 months, or kind of depending on circumstances, but hope that would catch it. But with clients that don't have that, it's sort of, you just have to trust the client as much as you can and continue to work on building that rapport and, meet them where they are. The book discusses not taking a history of sexual behaviors as it can be unnecessary. Is there any situation where taking a history may be beneficial? So when there are issues with sexual dysfunction or sexual behaviors, it can be important to have a more complete history. And so going into more details would be important there. Clients may come in with complaints about fantasies that they find disturbing, or urges or addictive behaviors like porn, masturbation, sex, so on. And so obviously these would be things that you would need to explore those kind of questions a lot more. And you may not always know this early in the relationship, and so it may come up much later, and then you kind of have to go back and ask some of these questions at that point. So an example I gave is if you've been seeing a client for a while, perhaps for an unrelated issue, and they begin to talk about some difficulties within their affectional relationships that impact their sex life, this would be a time where you may end up asking a client more about their sexual history. This probably depends on the site structure, but when communicating about sex with caretakers and children, how much consideration is given to time elapsed between meetings? Maybe this is too cynical, but imagining an abusive caregiver can have an impact on a child who might be disclosing. Okay, so this does greatly depend on the situation and the specific circumstances that you're working with, the client, the family, and also like within the sessions, what are the circumstances, what kind of abuse they've disclosed, things like that. And so if a client discloses some type of abuse and it's against the caretakers, I do not have to disclose to the caretakers if I feel like it would be a risk to the client. So I might make the report to whatever agencies I need to, if there are other agencies working with the family, but also, make a child line report. But I may not say directly to the parent, they're accusing you of these behaviors. It is not our job to investigate, so we don't have to, is this true? What's going on? We can leave that to Childline and give them as much information as we can. If I do want to follow up and have caregivers to ask questions about the child's relationship or interaction with someone else that the client discloses abuse by, then I may have that conversation with the caregivers so that maybe the caregivers can keep them away from other people or things like that. They may tell the child not to say anything, but I've already reported it because something came up, so it could be investigated. That's kind of in the hands of Childline. With young children, signs of abuse sometimes are more likely to come out in play or other creative therapies rather than verbally and directly. And so the child doesn't always have to say something. So even if the caregiver is like, shh, don't talk about that, like that's not something you talk about in counseling, or threatens them or whatever, you may see some of the things continue to come up, and you document those signs and report them as necessary. What kind of treatment plan would benefit young children with gender dysphoria? And so the question is a bit longer than that. You guys can read it in the document. So there are a number of things that can be addressed in these types of situations. Some of the therapy may be in helping the client to explore their thoughts and feelings. So maybe they have an idea that, they don't fit quite with gender roles or gender stereotypes. You can kind of help them to explore it. And again, depending on the age of the child, what does that mean for them? Do they feel like they just don't fit into gender stereotypes, or do they actually feel a level of dysphoria around their gender? Or in some cases, it could be that they are feeling that way because maybe they are starting to get an interest, an affectional or sexual interest in people who identify in the same gender, and that's leading to it. So it's really just kind of working with the client, processing their feelings, helping them to understand what they're going through. You can do this in play therapy, expressive art therapies, and you may see it in these other ways, not just verbally. It's also possible for younger children to receive hormone blockers that prevent puberty from happening in the biological sex, and then down the line, they can use, hormone replacement therapy. But sometimes hormone blockers, if the parents want to go that route, they feel like this is strongly enough, you're aware that the dysphoria is strong enough that you want to do that, you can do that, and they can always stop taking the blockers at a point and go through puberty in their biological sex. So it makes it less intrusive, I guess, of an intervention than HRT. And HRT wouldn't be used until typically the client is a little bit older anyway. So I feel that education is important, so educating the client and the caregivers as best we can about their options and what different things would mean. We wouldn't make suggestions or advise clients toward or away from any medical treatments. We would just give them the information as best we can and help the parents and the clients to make the decisions they need to. We'd be also addressing if there are other mental health issues present that could be impacting it. I know that different eating disorders and stuff like that, body dysmorphia, can sometimes be combined with this or make this more complicated, and so you want to address those issues as well. And more of this is explained on page 178 of the WPATH Standards of Care, so you can take a look at them to have a little bit more information. If you have to ask parents what questions are appropriate for their children, couldn't this potentially prevent detection of sex abuse? So it depends. We can ask caregivers what type of language is used around their child or with their child, or how much knowledge they believe their child has about sex and sexuality. But I also think that directly asking the question is okay. So, for example, I might ask the child in front of the caregiver or not, has anyone ever touched you in a way that makes you feel uncomfortable? This may produce a whole wide range of responses, but it could also bring out something significant. In some cases, we may not be aware of the abusive situation for a while into treatment, and something comes out later on. We can also, engage in some questions down the line. If a client uses vulgar sexual language, do you use their language or your language, or do you correct them? And this depends on a few things. One, your comfort with the language, your relationship with the client, and also what way the language was used. So often with slang, you may have to clarify what the client means. So even if you think you know what they mean by that slang term, they may not mean what you think it means. And so an older term that has been used historically was, third base. I went to third base with that person. But it can mean very different things based on when and where you grew up. So some people see third base as using their hands, under clothing to touch, breast region or genital region or whatever. Other people see that as oral sex. And so you might want to clarify those kind of things. Clarification can be helpful. In addition, if it's language that I don't typically use, it may sound really inauthentic for me to then use it. So I may use my own version of that, maybe the correct versions, but I wouldn't necessarily force the client to use those unless it was something completely derogatory towards me as a therapist, or a gender, that they're calling, an entire gender a certain word or things like that. And I usually clarify early on, especially with my adolescent clients, that they can use whatever language they feel comfortable with in session, as long as they're not coming at me with it or, things like that. And that I would address it at that time. I feel like the language you're using is really derogatory to just this entire gender or class of people or whatever. Let's talk about that, or let's think about our language usage, stuff like that. So it kind of depends. If the counselor suspects child abuse from the caregiver, how can counselor ask questions about the abuse or the adolescent? Okay, so again, go back to my previous answer. This is why reports of abuse may not come out until like rapport has been established and maybe you've been working with the client for a while. I'm honest with clients when I need to report. I let them know. We process their safety and why it's necessary for me to report. Some become angry and I tell them that that's okay if they're upset, and I understand that, but I also want them to be safe. If the child's old enough, you can safety plan. Do they have access to a phone or a relative or a neighbor, something like that they can go to. In regard to gender identity, if the client uses pronouns, is it okay for the counselor to acknowledge to the client that they don't know them but are willing to learn? Absolutely. It is very important for us to be authentic and honest. If we're not being honest, the clients are going to detect it anyway, and it's going to create like a really negative vibe within the relationship. So some clients may request someone who is more experienced with this area, and don't take that personally. I know that all of us as counselors need to learn and grow, but it's also okay for clients to feel like I don't want to have to, educate a counselor or things like that. Some clients will be okay with it, and they're just fine, moving on and helping you to understand what you want. And I think it's our job as counselors to get that education elsewhere and not expect our clients to educate us overall. So look up those things, get comfortable with it. Only ask the client questions that are related directly to them. Like, so in what way do you use this? Or what does this mean to you? Versus like, tell me all about gender language. Apologize when you make a mistake and move on. Don't make the session about you. Like, oh, I'm so sorry. I can't believe I mispronounced you or misgendered you or whatever. Don't dwell on it. You apologize, you try to do better, you move on. That's it. Practice using gender-neutral pronouns. Tell a friend a story. Instead of using like he or she, use they, ze, zir, other pronouns. And do as best you can to kind of practice that outside of session. The text stresses the importance of discussing with caregivers any questions that are appropriate with young children. What happens if the caregiver did not want the discussion to take place, but the child brings it up during an individual session? This can be a tough one. You want the client to feel free to talk about what they want and ask for their needs. But you also know that as a minor, the parent is involved and gives consent. If the client brings it up, I may sidestep it a bit and then share with the parents, hey, this keeps coming up in sessions. I know that you said you didn't want me to address this with your child. However, this is something your child is obviously curious about. You could work with the parent about learning to talk with their child, like kind of coach them and stuff like that to learn to talk with the child about it. You can, further kind of talk about, with the parent, the importance of, you being able to talk about this with the child. You can do it as a group, bring all three of you in the session and talk about it. And so there's different kind of things. At the end of the day, if the parent says, I don't want you to address it, then you try to do the best you can without going back to it. You can educate parents again, letting them know, like, why it's important, how it's important, and things like that. And they may leave treatment, and that's okay. You did the best you could to take care of that child, and so there could be lots of different ways to handle it depending on the situation. The text states that sexual problems are named as one of the leading factors for contributing to divorce. I'm curious to know how many of those divorced individuals also have a mental health issue. It's a very interesting question. I'm unsure of the direct answer to it, but I would say that this is a really great topic to explore and to research. So I don't know if you'll find a lot out there. You can definitely take a look, and if you don't find a lot, then maybe this is something that you can explore, you can take on as a research agenda. There are definitely known side effects, sexual side effects of different medications for mental health issues, and so that'll be something you could explore with a client. And mental health issues can also have an issue on like drive, libido, decision making, stuff like that. So again, stuff you can address with the client if that comes up. At what age is it appropriate to ask questions about sex to a child? Sex and sexuality education happens from the time we're born, whether we like it or not, whether we want to admit it or not. I had family members livid with me when I refused to find out the gender of my baby before she was born. I believe that we should use proper pronouns, proper names, body parts for children, and allow them to be exposed to age-appropriate information from the beginning. So, like children want to explore their body. If they're touching, different body parts, you don't say, ew, yucky, don't touch that, because then they think that their body is ew, yucky and shouldn't be touched, is the message that they're getting. And so we should just say, oh, that's, oh, you're curious about that, and tell them the proper names and stuff. Or, oh, that, when we touch ourselves like that, that's usually something we kind of do in private. We don't do it out, with others around, or, in the middle of the living room, or whatever the case may be. I don't feel there's an age limit on question or asking questions of kids. It can really just depend on the circumstances. Put it in terms that they'll understand, but also make sure that you're redirecting them to the proper terms, so that it's not like you're putting words into their mouth. So if like they call their vulva area a hoo-ha, you can say, okay, so you call that a hoo-ha, it's called our vulva. But you can continue to use their language, but don't put language in their mouths. So we wouldn't want to be coming up with these sort of slang terms for body parts. We would want to use the proper ones, if that makes sense. Okay, what is gender dysphoria? Wouldn't using that term to diagnose a client be unethical? It would not be unethical because it's an actual diagnosis in the DSM. And so if the client has that disorder, we would diagnose them with it. Unfortunately, it's, a disorder because it's in the DSM, but we call it gender dysphoria because it's not really a disorder. We don't believe that it is. And it used to be called gender identity disorder, and we changed it to gender dysphoria to make it a little bit more accurate to what is happening. And so it would only be unethical if we labeled people with that didn't actually fit the criteria. But having a diagnosis of gender dysphoria is necessary for clients to get hormonal and medical treatments that they may need. It is much more accurate, less stigmatizing way to explain what the client is experiencing. Although all individuals diagnosed with GD will desire any medical treatment or hormonal treatment, we can assess the client for this and advocate for them if they want any different types of treatment. We can write them letters and things like that, educate them. As well. It would only be unethical to diagnose them if they didn't fit the criteria. The first and second questions are related to my first observation. I would like to know reasons why sexual education classes are offered at a minimum or not at all in school. You really hit the mark with your guesses. If you want to read this question a little bit further, you'll see kind of some of the areas of thought process that the student was going through. There's lots of disagreement on what sex education can be taught due to those who feel maybe against their religious beliefs, or that the discussion would cause young people to start being sexually active sooner. Many places in this country offer little or no sex education, and in some places it legally doesn't even have to be medically accurate, which is astonishing, that we can kind of give young people information that is wrong and know that it's wrong. So my experience with, for example, my stepson, when he was in school, parents could sign a form that said they did not want their child to be present. So the school said, we're going to be teaching this. If you don't want your child to be present during this discussion, we can pull them out if you sign this paper. I think that educators can do a fine job with this. I don't think it needs to be counselors or school counselors or anything like that. But that's only if they have a good education on how to appropriately do so. And so I think that we would need to educate the educators so that they can then educate their students. Studies that show a correlation between children and teens that receive sexual education and those who do not. This has actually been studied extensively. While I don't know the specific results of these studies, it is apparent that lawmakers are either completely ignoring it and not really addressing this issue, or they are just, kind of refusing to believe it, even what is out there. I know the book says that counselors should discuss with parents any questions, so we're going back to kind of, how to talk to children about it, depending on parents' wishes. So I think that the point the book is trying to make is that adolescents may be more likely to hold back in front of their parents, and that parents may desire to hold the child back from discussing these things, but that it's necessary to do so. So I think it's a good idea to include the parents on the conversation, or at least make them aware that it is happening rather than just do it behind their back. But I also recognize that adolescents may have more questions and more to discuss than young children. And so, again, it's very dependent on the age, the parent situation, things like that. And so kind of have to take it by a case-by-case basis, and this is one of the good things about doing supervision or consultation when we're working with clients. Okay, how would one approach a situation where the child meets criteria for gender dysphoria, but comes from a family in which this is incongruent with their beliefs? So the counselor could potentially be a sounding board for the client, so just a place for the client to talk about it and address the issues, and have one person at least that's affirming and understanding and whatever in their life. There isn't a lot you can do since the child is a minor and under the supervision of their parents, but you can try to discuss the issue with the parents, educate them on, as much as you can without kind of pushing against their beliefs. You may, be able to talk to them about, at least parental acceptance, because there are lots of studies and information out there on how this can be so impactful for the young person, that if they have, supportive family members, even minimally supportive, it's better than not having any at all. You can also get the client linked up to outside resources and support. So maybe a support group or like an online community or something at their school, like an LGBT support group, things like that, so that the client, again, doesn't feel quite as alone. What sexuality assessments inventories can be used to help explore the sexual orientation adjustment of a young man or an adult man who identifies as male, has the anatomy of male, but expresses sexual preference for women, however, states that he's more comfortable establishing, maintaining close bonds with males and actively seeks them out. This one is complicated. I'm not sure if there's a specific assessment out there for this. You can always kind of explore the client's feelings and how they react to their feelings. Are they comfortable with it? Do they want something to change? Do they feel they need to have a label? And so on. And so, the truth is that there's so many different factors that play into this, because, our sexual and affectional desires may be very different than our sexual behaviors. We may also be affectionately attracted to a certain specific gender, or even, individual characteristics, but, sexually maybe we're attracted to a broader range or even a smaller range. And so it's very complicated and again, sort of depends. I hate saying that to all of these questions, but a lot of it sort of depends. What assessments are used to address human sexuality, sexual identity with clients undergoing counseling prior to sex reassignment surgeries or cancer-related treatment medical procedures? So, gender affirmation surgery is actually the correct term. We don't use sex reassignment surgery, that term anymore. It's for individuals who feel their body and anatomy do not match that of their gender identity, which was assigned at birth. So we use assigned male at birth, assigned female at birth, acronym AMAB or AFAB, and they may desire gender affirmation surgery or hormonal treatment to affirm their gender identity and still find themselves attracted to the opposite gender of their birth. So for example, this was someone who was assigned male at birth. They may feel that they have a female gender identity and actually, do the affirmation treatment and surgery, but still be attracted to other women. They may consider themselves to be a lesbian because they identify as a female and they're attracted to females. It happens all of the time in the reverse way and with gender nonconformity and all of that. And so gender identity does not equal sexual identity. They're two very different things. But I'm unsure about what the part with the question of cancer treatment related medical procedures, so I didn't address that because I'm not sure what the question was as far as that's concerned. When should parents start talking to their children about sex? At what age? So at birth. So seriously, this is an ongoing conversation. As a child is growing and developing, this involves teaching them the correct names for their body parts, teaching them that their body is their own and they should, love their body and their body is not icky or gross or anything like that. They can say no to hugs and kisses and other touches by other people, and that they need to respect other people's boundaries. No means no, and no doesn't mean keep trying to coerce me or push me into it. Teaching children to accept no as an answer, not coercing others, is really important. It goes a really long way in helping to change our current sexual culture, which is not okay. And this education is happening again indirectly, whether we like it or not. So at least we can try to work on improving what that education looks like. And again, it can be taught in very different ways and in very different circumstances as a child grows up. Another student, I tried to do exercise 2.2, sexuality related language, and I was not able to generate a list of 30 words related to sex, sexuality, or sexual intercourse. And I know that this activity could be really hard with an online class. So what I said was that in a face-to-face environment, I actually love this activity where the class as a whole maybe breaks up into groups or whatever and identifies different language that could be used by clients to mean these different things. And then we sort of yell out these words to increase our comfort with both hearing them and saying them. And I was trying to figure out how I could replicate those for the online environment, and I just really wasn't able to come up with something. So if you all have any ideas or suggestions, that would be awesome. We can try it. But other than that, it's just best to sort of keep trying it on your own. Maybe talk to friends or other people in the class that you can, face to face with, that you guys can sort of try this. The text mentions allowing clients to disclose their own sexual identity. However, during intake, wouldn't we ask what's your sexual identity or orientation? And this may be true. And this doesn't seem to make sense, right? Two totally different things you're being told. So it is typically part of our initial assessment to ask sexual identity, affectional identity, sexual behaviors, things like that. However, clients can choose to skip this or maybe not be totally honest with us at first. And so we shouldn't push them. We should just kind of allow them to come out with whatever they're, able to come out with at that time and recognize that their truth can change and stuff like that. And so we don't want to push them to disclose anything that they don't feel comfortable with. But this can be, I recognize, a difficult line to straddle. How do we go about caregivers who are not comfortable with us discussing this with their child, but the child wants to discuss it? Again, kind of talked about this a little bit before. We can do some education with the parent if they're okay with this, letting the parent know the importance of this and how to do it in a way that's not directly related to sexuality, like just teaching them that their body is their own, consent, non-coercion, and teaching their child that in other ways as well. And hopefully we can increase their comfort and they can start facilitating the conversations with the child, or we can kind of act as a mediator there. The textbook stresses the importance of sexual education, yet sex education is hardly if ever taught in school. Why is that? So go back to what I've already discussed on this. People have different beliefs and lawmakers have not pushed this issue further, have not been able to push it further. As I've stated in Chapter 1 OQEs, the ACSSW organization is advocating for more sex education, specifically at the graduate counselor level. But it is at least a start for us to increase our knowledge and awareness, and it could be advocacy work that we all engage in. If clients identify any sexually related concerns during the general assessment, should they be referred out to an expert? And again, it depends. If the client has a significant issue that's outside of your scope of practice, then yes, they should be referred out, and they could be referred out completely to a sex therapist, or they could be referred out to a sex therapist and you continue to work with them on the other mental health issues. It sort of depends on the circumstances. But it also doesn't mean that you can't help the client with those issues either, because some of them are related to their mental health issues. So if a client's having, issues with anxiety, and that's, kind of moving into their sex life where they're not able to, focus and then maintain an erection, or they're having premature ejaculation, or, for a female, they may not be able to reach orgasm because of the anxiety. Those are things that we may be able to address together. So we work on the anxiety in whatever circumstance it's happening in, and then maybe that'll help the client in the sexual aspect of their life. So it really depends on how significant the issue is that comes out. When addressing client sexual history in relation to existing concerns, how can a counselor avoid intrusive interrogations? Is it possible to understand presenting issues by focusing on the here and now? So as counselors, we should bring up this topic and ask some basic questions at the intake assessment. We do not have to engage in extensive questioning unless we're trying to determine a fit for counseling, or if we need to make a referral. We can also ask more if we feel there are some related issues or safety concerns present. Clients can also refuse to answer our questions, which is always a possibility. And we can deny services if we feel like the client is unwilling to address areas of need. So it depends. So, if a client's here for this issue, they don't want to deal with this, you feel this needs to be addressed, but it's okay to deal with this without this, you just hope that the client one day continues. But if you feel that these two things are combined and the client's unwilling to go there, or unwilling to address things that are really impacting the things that you're working on with them, you can say to them, I recognize that I'm having a limit here, that without addressing this, I'm not sure how we can get to this. And so, if we were to continue counseling, I don't know how effective it would be. And so I can give you a referral to another counselor if you'd like, or, we can kind of revisit this at a future time or whatever. So you just kind of talk it out with clients. In regards to assessment, I practice art therapy and pictorial analysis as well as verbal assessments to better understand clients' perspectives when it is appropriate for the counselor to share their perspective, finding, and insight without negatively affecting the therapeutic process. As always, it depends. A lot on the theoretic orientation of the counselor and the relationship with the client. And so depending on what your theory is that you kind of feel that you work from, that would determine it. As well as how well you think that the feedback will go with the client. And so you need to use those factors to determine when or if at all it would be a good time. And it can be done in a gentle and productive way. You can kind of practice that and prepare yourself for that. Sometimes you as a therapist, just knowing that information is helpful enough for you to get at things with the client, and you don't even have to necessarily directly give them the feedback. I would like to know how receptive parents are letting counselors discuss sex with their child. This is really highly dependent on the parents. Some parents don't want to do it themselves and are happy to pass that along to you. Some parents feel like they've already had some discussion and they don't want you to do it, or they have had some discussion and are okay with you doing it. And other parents are just adamantly against it. Like, I don't feel like this is something that needs to be discussed at the client's age or whatever. And so they may even dictate what beliefs are okay or not okay to explore or affirm. I had a parent tell me that their daughter, the daughter was the client. She had disclosed to the family that she believed that she was bisexual. She said that I feel like this may be sort of who I am. And the father came in and was like, I will stomp all over that. We do not agree with that, yada, yada, yada. Like, we need to squash this right here. And I just kind of explained to him that my job was not to change the client's beliefs or feelings, but to explore them with them and help them to feel comfortable. And, that I could not change her identity, that wasn't going to happen. And so it was a difficult conversation to have. But, so, he was okay with talking about sexuality, just not me affirming the fact that she was exploring her sexuality and thought that, hey, I might be bisexual, and this is something that I want to discuss further. Also, what are some viable techniques to get parents okay with discussing it? You can just approach the subject delicately, kind of bring it up at different points, try to educate the parent. Also, you can let them come to terms with what the child keeps bringing up. Just say, hey, this came up in session again. Just wanted to let you know about it. It may be something that really needs to be explored. And so depending on the involvement of the parent, how involved they are in counseling and your relationship with them, there may be a number of ways that you can kind of sort of keep working on it. But at the end of the day, the parent keeps saying no, they say no. If a child or adolescent discloses they've been assaulted by a caregiver, is it safe to keep the caregiver away from the child until DCF and the authorities arrive? So, this is dependent on a couple things. One, we can't keep the caregiver from taking the child. That's not our place. We do not have the authority to do so. Also, if we make a child line report, authorities don't come right away often. Usually they take the report, they do whatever internal stuff needs to be done, and then they investigate after that. The only situation I feel like it may be a little bit more pressing is if a child comes in and has like visible marks, or there's some kind of medical issue, like you question whether a bone is broken, or a severe significant case. That is a case in which you may have to call the authorities and you may have someone respond right away. I'm thinking about in-home, if you do in-home counseling, that may not go over well with the parents, but you may have to make that phone call, and maybe even you may be told to leave, or, so it kind of depends on the situation. But we are not investigators. We do not hold any authority to hold a child away from their caregiver, anything like that. And so one thing that could happen is, you either make the call while the child is there, or even after they leave the office, and then you just kind of keep your fingers crossed that your report was enough to help prompt an investigation, hopefully one that occurs as soon as possible. And in the case where it is the caregiver and you feel that there's substantial enough evidence that it's the caregiver, you may not want to tell them directly, hey, I called, child line on you today. You may express to them, like, I have some concerns about like bruises or marks, things like that. But again, it's not our job to investigate. And so there may be this difficult line we have to walk. Make sure that you're talking about this with supervisors and consulting other professionals, because again, each situation is different. And so you want to make sure you address each one individually. And also within agencies, there's different rules and things like that. So you want to make sure that you have those, good awareness of those. In the cultural contextual issue section, we learned about various instruments available that specifically are not racially or ethnically diverse and may be limited for our diverse clientele. Are there assessments that are related to sexuality that have been created for diverse populations and take into account various cultural values and beliefs? Very few. You will have to search high and low for these. But there are some that exist. Some that exist have not been studied on large populations, and so they may not be as valid or reliable as we'd like them to be. And so this is a great area of need within our field. If you're interested in exploring this further, I would say go for it. See what's out there. See how much they've been studied. Conduct studies on ones that are out there so that they get more empirical support and evidence, or even create your own. But this could be an entire research agenda for your doc program, your dissertation, and even for a tenure. And reach out to some of the people out there that are doing the work in this field, so that you can connect on whatever it is they're working on. In the developmental issues section, we learned that sexuality is important with younger clients. How should counselors balance promoting sex education with parents who are more inclined to keep this a taboo subject? This is mostly already discussed. Keep educating parents and keep them in the conversation. The book mentioned it can be empowering for clients to locate their sexual difficulties as resulting from systemic causes rather than internal shortcomings. What would an example of this be? So it could be a poor relationship, unhealthy relationship. So maybe the sexual issues are related to their specific partner because there are other challenges. It could be unhealthy cultural religious values being placed on the client or causing them to struggle. Abuse and trauma history, or even currently happening, can have an impact. Unaddressed mental health issues, and so on. And so there are a number of ways that factors outside of ourselves can really impact our sexual abilities. I wonder about discussing sex and sexuality with a child. I know that there are many factors that would contribute to this, like presenting issue and parental approval. But how would a counselor proceed if the parents decide they do not want the topic discussed, but the child brings it up? So again, kind of talked about this already. We can't really go against the parent wishes, but the child, if they are going to keep bringing it up, you keep bringing up to the parent that they keep bringing it up, and the importance of the conversation, continue to educate them. You can even, again, facilitate a conversation with them and their child. So just do the best we can. If the parent is the sexual abuser, the child would giving them or asking them permission about asking these questions put the child in danger. Not necessarily, especially if we ask it in front of the parents, the child is not likely to disclose at that point, but the child may bring it up when the parent is not there, or kind of bring it up in their play or things like that. So even if you don't ask the child directly, it is likely to come out in other ways, again, so we can be mindful of that. And we can always do the best we can on this topic and gather information from the minors when their parents are unwilling to agree to this discussion directly. Is gender dysphoria ethical? That was sort of a question before. The diagnosis is not unethical because it is a diagnosis within our DSM-5. Unless we label a client having this diagnosis that does not actually have it. The issue of dealing with our highly gendered society, especially the binary nature of gender, can lead to dysphoria in individuals who do not feel that their gender assigned at birth matches their gender identity. The unethical part would be to give the diagnosis without an assessment, so you have to do a proper full assessment. And if we were to refuse to address these concerns in clients we're working with, that would be unethical. And if you feel like you're not, capable enough, you're not educated enough, experienced enough, then you can always make a referral. But don't ignore the issue and the client. Why do sexually related disorders get so little attention in diagnosis training? This is because they are a small part of the DSM. In many cases, there are just so many different diagnoses that we need to go over. These also don't show up often, and so they are processed less because we don't come into contact with them much, and there's really not that many in the DSM to begin with. And so specialists like sex therapists would have more training on this. But if you want to have more, there's definitely trainings out there that you can get outside of your program. And hopefully as time goes on, we will incorporate some more accurate diagnoses within the DSM too, because there's just not a lot in there right now. Should sexuality related questions be included in every intake form? To some extent, yes. You do not have to go into great detail, but asking some basic questions, and then, as your treatment with the client goes on, you may have to ask more later. So you can just ask if they're sexually active, if they have any concerns with their sexual activity or their sexual behavior, they practice in safe sex. You can ask if they've ever had or currently are having unwanted or abusive treatment by others, or if they're doing it to others. If they have concerns about their thoughts, fantasies, behaviors, you can ask about their sexual, affectional, and gender identities, things like that. And then if things come out to those questions, you may have to ask further questions. In the same vein, I was wondering what we're supposed to do as a clinician if a parent does not want you asking those questions. Address this above. There's only so much you can do. Don't push the parent, but you continue to educate them. How do we bring up sexual addiction and unsafe sexual practices without alienating a client? How do you provide validation without encouraging unsafe practices? So you come at it more with curiosity. So for example, if a client says something that leads you to believe that they're engaging in unhealthy sexual behaviors, you may ask, hey, I'm wondering a little bit more about that. Is that a common experience for you? Or how do you feel emotionally when that happens or when you engage in that behavior? Or even what is the impact on you when that happens? What's the impact on the other person? And so on. And so you can normalize it by saying that, there are clients who, lots of people who feel this way. Or that sometimes that happens to situations or to people. You can also help them to see that it's not necessarily their fault, that there's a lot of circumstances and factors that go into it, and help them to kind of get in the right direction, kind of lead them in the direction that is best for them. And so those are all of the questions for Chapter 2. I will post another one of these for Chapter 3. Keep the questions coming. They're really great questions. They're really interesting, and hope you're getting a lot out of seeing your peers' questions and being able to hear these responses. So thank you.